All right, looks like we're leveling off now, so I'm going to go ahead and get us started. Welcome to the 2024 OVS VAP Training Center webinar. This is Considerations for Trauma-Informed and Victim-Centered Correspondence. I'm Blake Cush. I'm the Training and Outreach Unit Chief at OVS. Our Director B. Hansen is unavailable to join us today, but she does send her best wishes. In just a minute, we're going to turn things over to Dr. Amy O'Neill. But in the meantime, I'm going to cover just a little webinar housekeeping. For today's webinar, we've enabled both the Q&A and chat features. Please use the Q&A tool to ask questions only, and then use the chat feature to react and interact from prompts that Dr. O'Neill may have throughout the training. Both Lauren and myself, who you also see on the screen there, are going to monitor the activity throughout the presentation. So we'll make sure to try and catch any unanswered questions or reactions that are needed. Slides from today's webinar are available, and a link to them will be shared directly in the chat in just a minute. Today's webinar, as you just heard too, is also being recorded, and we will publish that on our YouTube channel in the coming days. So this is one of many webinars that we offer periodically through the VAP Training Center. And if this is your first time joining us, welcome. If you're a repeat attendee, thank you for coming back. Our unit oversees many professional development opportunities and resources, including the recent OVS Seeking Solutions Summit we hosted in Skinny Atlas this summer, our biennial OVS conference. Our next one will be next August. More details coming soon. The Training and Technical Assistance Request Program, or TARP, OVS Resource Connect, and VAP Connect, which is an online community forum for advocates such as yourself to network and share best practices. More information about all of these opportunities and resources can be found at ovs.ny.gov/training. So that and links to today's recording and the slides will also be shared with all of you via a post-training follow-up email, and that'll come in the next day or so. Finally, when you do exit today's webinar, you will be directed to an evaluation survey on the presentation. Please take a couple minutes and give us your feedback. It's incredibly valuable, and it helps us all make improvements. And just before, a moment ago, we were just talking about how we are continuing to learn and grow as an agency, a state agency, an organization, as individuals by those feedback remarks. Like, they're incredibly valuable to us. So we share all of that with Dr. O'Neill as well to help her improve any future trainings that she offers too. So that's our housekeeping. I'm going to transition now and actually formally introduce Dr. O'Neill. So Amy O'Neill is a licensed professional counselor who's worked in the mental health field for over 30 years. She serves as an independent consultant for the OVC VOCA Center, OVC TTAC, and the National Mass Violence Resource Center. Ms. O'Neill has developed a number of learning communities and specialized training and technical assistance, and has presented at numerous national and international conferences and programs. Ms. O'Neill also maintains a private counseling practice, is an adjunct instructor for the graduate counseling psychology program at Chestnut Hill College in Philly. Ms. O'Neill holds MS in counseling psychology and a doctorate in health sciences with mental health concentration from Bay Path University in Massachusetts. I hope I did that justice. Let's please welcome Dr. Amy O'Neill.
I got myself unmuted. Let me get my slideshow set up here. Good morning. Thank you for having me, Blake, and thank you to the office, New York State Office for Victim Services. This is such an important topic in training, and it's a hot topic right now across the country. OVC has been doing a lot of training with victim services organizations across the country, really focusing on how to make victim services more trauma-informed. As you all know, this is a very dynamic and changing topic. The language changes, best practices change. So the ability to have the chat feature enabled so we can always keep learning from each other is super helpful. So thank you for having me. I'm going to skip my introduction because Blake, thank you for doing a great job. I just also want to add that I am not just a consultant and provider. I've worked in mental health for over 32 years, but I'm also a survivor. So I was somebody who was directly impacted and injured at the site of the second explosion of the Boston Marathon bombing and went through the comp process. And I'm just going to set that as a stage backdrop for the conversation today. Going through the comp process, working in mental health, having knowledge about the field and the system and how it works, coming from a place of privilege, I found it completely overwhelming. So I wanted to share that as well. The goals for today's session, I'm going to keep short. It's a high-level overview of trauma, the core principles of trauma-informed care and victimization, how trauma impacts those that we serve, and what we can do with our own interactions and communication to improve trauma-informed care and protect those that we're working with. Just want to give a little content warning here. We are talking about, trauma. We're talking about the kinds of things that people experience that bring them into our spaces of victim services. So just wanted to put that out there and make sure if at any point there's something said that's uncomfortable, please always take care of yourself first. I was going to ask who's in the room. Lots of people did that in the introduction, so glad to see people from all over the great state of New York. And I'm happy to report to you that I'm coming to you today from New York City. So if you hear a siren out the window, that may sound familiar to anybody from the area. And I always start these sessions with a thank you. Thank you for choosing this work. Thank you if the work chose you. And to take this opportunity to think about the content here through two lenses. One is as a provider, and two, as a person, and how you may have been impacted by trauma that either led us to this work or what you've learned about yourself through doing this work. So thank you for being here. And I think victim services, we don't always get the acknowledgement for the hard work that we do. To set the stage for the conversation, this quote is from a book called Trauma Stewardship. I use it in the classes that I teach. I find she was actually a keynote speaker at NOVA conference this year, if anybody went. And I think that it's an excellent resource if you're doing this work and you just want to learn more about how to protect yourself in it. So this is for anyone doing the work to make the world more sustainable and hopeful, all in all a better place, and who through this work is exposed to hardship, pain, crisis, trauma, or suffering of other living beings or the world itself. So thank you. Part of trauma-informed care is also learning how to take care of yourself through this journey. Wanted to start just by thinking about the word trauma and what it means to you. You can see on this slide, I have elder abuse, IPV, human trafficking, stalking, just some different experiences that people come to you with that they've endured. They come into your spaces because they've endured these things. So when you hear the word trauma, if you're inclined, put in the chat what that word means to you. What comes to your mind when you hear that word? Accumulating different ways to help describe the word trauma can be really helpful. Some people have a unique way of describing that helps us inform how we think about the people that we're working with. When we talk about trauma, one of the essential elements is to remember that trauma is an emotional response to a terrible event. It is an experience, it's not a diagnosis in and of itself. So because somebody incurs a traumatic experience doesn't mean that they have PTSD, or it doesn't mean that they have an adjustment disorder. Post-traumatic stress disorder and an adjustment disorder are the accumulation of the consequences of experiencing something traumatic. So it's a terrible event like an accident, experience rape or sexual assault, natural disaster, stalking, intimate personal violence. And there are considerations in the immediate aftermath and the longer term on what it means to have traumatic stress reactions. So according to SAMHSA, one of the definitions is it's an emotional or physical response to one or more physically harmful or life-threatening events or circumstances that have lasting adverse effects. Obviously, for the clinicians in the room, the DSM goes on to talk about the accumulation of trauma and what that means diagnostically. But just from a stigma perspective, everybody that experiences a traumatic event isn't traumatized and doesn't have PTSD. And yet there are reactions that we can look for. And just to set the stage, and I know that many of you doing this work already know this, but in the United States, intimate partner violence, domestic violence affect a large portion of our population. Some of the statistics say that it's up to 10 million people, individuals annually. If we look statistically, 1 in 4 women, 1 in 9 men, and this cuts across culture, race, gender, age. So when we think about trauma-informed care and trauma-informed victim services and trauma-informed correspondence, we want to always be striving for better. Better is better, and being aware and being intentional can help folks along their recovery journey, and that we can sort of help move away from re-traumatization by what we write or what we say and how we interact with our community. Individual trauma is an event or circumstance that results in physical or emotional harm, as we just described. It can have consequences on mental health, physical health, emotional health, social and spiritual well-being. So we put the word trauma on the last slide. We put these experiences around. And in the work that we do, we also want to acknowledge that people's experiences also have an impact on us. Trauma-informed care is not just us understanding what somebody's coming to us with, it's also us understanding what it does to us and in the work that we do. People share the worst experiences of their life with you. It is heavy, and we want to find ways to put it down. And that is how we can also continue to be trauma-informed. And I know I've thought this at different points in my career. I've heard stories where I thought, I can't even imagine how this person is living with this suffering that they've shared with me. At other times in my work life, I've thought, somebody just shared something awful with me. I know it's really bad, and I don't know why I'm not having an emotional reaction to it. And those are two pretty extreme examples, right? One being sort of hyper aroused and one being kind of hypo aroused. And I think it's important to note that as victim service professionals, we may swing between these two states of how we experience what people share with us. No matter what our experience it is, hearing what it is and hearing how we react and having peers to discuss that with is a way to keep us healthy in this work. Our goal when somebody comes to us when they've experienced trauma, and this is really a psychological first aid skill, is to be able to listen actively, help promote safety, avoid judgment, and validate their experience. We don't have to be a clinician to do that, but psychological first aid, if you haven't taken it, Skills for Psychological Recovery are 2 free trainings with skills that will serve you long through any career in victim services or working with people that have had to endure difficult circumstances. And it's a privilege, right? And it's an honor. I know it is for me, you know, when I'm working in direct service, that people share with me, or to create a condition where they can come and share the most difficult experience of their life. As many of you know, there are many types of trauma. I gave you the definition for individual trauma because oftentimes we're working with people one-on-one. Sometimes at the community level, we're dealing with a collective trauma. I know that there was a collective trauma with the hate-motivated terror attack in Buffalo. We also have historical trauma, race trauma or race-based traumatic stress, which is the cumulative effect of racism on an individual's mental, behavior, and physical health. We have intergenerational or generational trauma, and that's what we pass down from generation to generation because we've endured hardship. Vicarious or secondary trauma is what we can be at risk for in this work. Hearing those stories, hearing people share details of experiences that they've had can put us at risk. So taking care of ourselves, I'm going to keep plugging that all day, is essential because we need you. We need anybody in this field to be healthy and well and always growing and developing. An essential element to being trauma-informed is understanding that traumatic experiences layer and stack on one another, increasing vulnerability for adverse impact. I know many of you already know this. This is a global review and a high-level overview. But if we look at things like the ACEs study, right, we know that 4 or more childhood adverse experiences put people at higher risk for adverse reactions to that. So why is it important to know that traumatic experiences layer and stack? Because when we meet somebody where they are, when they come in to us for services, whether it's compensation, whether it's as a victim advocate, or even in a legal context, we need to know that we are meeting that person with the accumulation of all their experiences. So if somebody has endured a generational trauma, race-based traumatic stress, and other individual trauma, their risk factor is going to be higher for adverse reactions or impacts of the accumulation of all the trauma that they have endured. And whether we see ourselves or not as people in positions of power, working as a part of an institution or part of a system or for a state or county agency, we are. And acknowledging that there may be systemic mistrust based on historical, collective, racial, and injustices, we need to know that going into things, because the more trauma informed we are, the more opportunities we have to build trust in the system so that we can serve those impacted in a better way. Now, again, this is a high-level overview. That topic could be a 5-day training, and it's an essential conversation to keep having. But, you know, for the purpose of today, wanting to acknowledge that, you know, historical trauma, race-based trauma, collective trauma, intergenerational trauma, we have a legacy of mistrust, betrayal, harm by institutions that are here to serve and protect people. So knowing that people could be reluctant to engage with us, knowing that people might not trust us, is real, and we need to acknowledge that.
Dr. O'Neill, we have a question about some trainings that you just listed a moment ago. One was psychological first aid. Can you name the others?
Yes, psychological first aid and skills for psychological recovery are both typically offered free. They're 6 hours. They can be accessed through the National Children's Traumatic Stress Network. And they're both skills-driven approaches to people under extreme stress, applicable to disaster, natural disaster, mass violence, and victim services in general.
Thank you.
Yep. Trauma, as most of you know, or many of you know, is also an experience that impacts our physiology. It's in our brain, and because it's in our brain, it's in our bodies. So it's also a physiological experience that can affect multiple areas of our life and affects everybody differently, right? We were talking about layering and stacking. So the more vulnerabilities I've accumulated, it's possible that, you know, it's going to impact my brain differently. So those with the prior history of experiencing domestic violence, sexual assault, physical assault are at more risk for higher adverse impact. And those that have experienced those kind of dramatic victimizations are also at higher risk for comorbid disorders or diagnoses. So things like substance misuse are a higher likelihood, right? So the more that our brain is under attack, the more vulnerable it becomes, the more dysregulated our body feels. And then oftentimes we look for ways to steady that dysregulated sense inside our body. And unfortunately, substances feel like they work on the front end, but cause additional issues. So I think it's important just to remember that it's not just an experience that somebody can emotionally like get over or move through, that there's some learning that often has to happen with people. That's not necessarily our job if you're not in a clinical setting to teach them, but it's helpful to know that it's not just that people are wanting to be angry, for example, or just taking it out on us. Sometimes that dysregulation is happening inside, and it's hard for people to even know that it's happening sometimes. This graphic, I think, gives us a better idea. We call this region between the prefrontal and the hippocampus, we call that the Mohawk region. So you can see in this photo, and I love this photo because it makes it easy to understand that when we are experiencing something that is traumatic, our prefrontal cortex, which is our logic, what do we do? It's our executive functioning. That system, that connection between our prefrontal cortex and our hippocampus, which regulates memory and emotion, weakens. When that weakens, what strengthens is our amygdala. That is our fight, flight, that stores memories of the event. It's the house of big emotion. It's where, you know, that dysregulation occurs. So that fight between everything's okay and I'm somehow defending myself or fighting for our life is happening in that brain, right? That's why we showed a picture of the brain. So when a person perceives threat or harm, it doesn't mean that they have to be under threat or harm in the moment. So think about what we were saying about the system. If I'm attempting to serve somebody that has mistrust for the system, and they come in to talk with me, they may feel under threat. And that perceived threat is coming from past experiences, it's coming from historical experiences, and that may activate this transition in what part of the brain that person's leading from. So this is why it's important to understand that the neurological impact of trauma. This is why sometimes folks that we're working with have difficulty organizing thoughts and interpreting information, become forgetful. Again, this is another area, the neurobiology of trauma. People study that for an entire semester in school. The implications of this kind of trauma on our brain and these kind of experiences, the psychological effects, I think are easily rememberable when we talk about them in three categories: emotional distress, cognitive impact, and behavioral changes. So if you can put a thumbs up or a comment in the chat, if you worked with somebody who is discharging towards you emotionally, you're having a conversation, you're trying to do the good work that you do, and you're getting sort of this intense reaction or response, or you're feeling this disproportionate emotional distress reaction as you're, you know, trying to help and be useful in your role. So I know I've experienced that. I know sometimes anger is something that we have to deal with. Somebody being forgetful, changing stories, caregivers, family members. So if you've had to deal with somebody that you, or work with somebody through a situation where you felt they were dysregulated in some way, just a thumbs up or some kind of acknowledgement. I think we've all had to do that at some point. You know, and this is tricky, and this is a great conversation, interagency, is what do we do about that? We want to be trauma informed, we want to help people, and we also have to protect ourselves. So it's not necessarily good for those we're serving or for us if we endure a lot of emotional discharge or inappropriate discharge because they're suffering. So coming up with language and ways to talk about that and how to intervene and support each other when that happens is a worthwhile conversation. Moving right along with the high level overview of trauma, common reactions. And experiencing trauma can interfere with a person's ability to organize and interpret information. So know that that's normative in this experience. We will repeat things. We'll ask for signatures, sending follow-up emails, or even a phone call sometimes. Oftentimes, we may see people having difficulty making decisions. We could see avoidance. I gave some statistics on domestic violence earlier. Victim advocates, system advocates, people that work in victim services, specifically with that population, or folks that have endured that experience. Patience and knowing that is essential to supporting them through their recovery journey, right? Because when somebody's disempowered and they can't make decisions, and now we're asking people to make decisions, it can be really overwhelming. People can feel fragile and vulnerable. And one area that I want to just highlight is shame and self-blame is common throughout all different kinds of trauma. And it's so interesting, right? Because shame says I've done something wrong, or something's wrong with me, right? So, and that's really awful burden for somebody to hold and to carry. And that shame does make people avoidant, and it does make people not want to come forward and share their story, because shame says, well, what if they think it's my fault? What if I'm denied eligibility? We'll talk about that word later for this program. Being denied that says, okay, because maybe I am bad. Maybe it was my fault. Maybe I should have been different. So, language and understanding common reactions in terms of how we put this all together to create our trauma-informed approach is essential. Anxiety, mood swings, depression, sadness, and irritability, just generally, I think everybody's probably had to encounter that at some point. And just a note here on common reactions, people are often unaware when they're activated. It's such a subtle dysregulation at first. We notice when anger is intense. We don't notice when irritability is festering. One of the most interesting experiences people can describe, or often have described, I mentioned this connection, right, between executive mind and amygdala, big emotion. People can see both. We can see the rational reaction, and we feel this urge to do something different. And there's this push-pull fight inside people's minds, often about how to react. So what we do in a trauma-informed way, always sort of trying to create safety, can sometimes help tip that scale back to executive function and sort of away from the perceived threat. We're going to take that high-level overview of trauma. Again, that could be a whole semester course in itself. So it's a high-level overview, and thinking about what this means in terms of a trauma-informed approach. A trauma-informed approach is a paradigm shift away from what is wrong with you, what's wrong with them, what's wrong with this person, why are they so angry, what's going on, to what happened to you and how did this experience affect you. So I like the book, What Happened to You by Bruce Perry. I think it's a great resource. He was sort of a notable childhood psychologist, but it really is pop psych reading, I think, for anybody. I will give you an activation warning that there's some difficult cases in there. But he was a big voice around what happened to you. Something happened, and that's why this person is carrying what they are. So being person-centered, not victim-blaming, trauma-focused, person-first, not incident-focused. So this is tricky little language things. I worked in substance abuse for a long time. It was very common. We called people, addict, alcoholic. Now we're talking about people with substance misuse disorders. So, we want to be thinking about, this field is always evolving, language is always evolving. How do we continue to strive towards person-centered? And then I highlighted here in yellow because we're all providers in some way, shape, or form, but acknowledging this provider trauma and impact, and think about ways to process that. Do you have a work friend? Do you have a mentor? Do you have a supervisor? It's normal. I know when I started my career 34 years ago, I felt like I had to always do everything right. I felt like I couldn't get overwhelmed. Stuff couldn't bother me. I was supposed to be able to handle it. And when I, look back on my career, I accumulated some numbness, some real calluses to things over time. So it's important to be thinking about how we can always be processing our own stuff. If you happen to pick up that trauma stewardship book, she talks about a scenario in there in which she first learned that her work had gotten to her. If you don't want to read the book, another resource is a TED Talk. She's got about a 17 or 20-minute TED Talk about the book, and it really captures the highlights of it. And I think most of us in this field will relate to what she shares. And sometimes it's being the person at the dinner party with the bad stories, right? Because we hear a lot. In efforts for consistency, I wanted to note that Office of Victims of Crime, OVC, defines victim-centered as a victim-centric approach is having a systematic focus on the needs and concerns of a victim to ensure compassionate delivery of services in a non-judgmental manner. That is our goal, right? So how can we include you? How can we support you? How can we work with you? Coming from that place of yes, and how can we help? I understand specifically in the comp process, we can't say yes to everything, right? There's criteria that people need to meet to be within the guidelines of the program. But I heard from the master, the special master for the 9/11 Victims Compensation Fund, this is one of the approaches they're taking with their staff. We are coming from a place of yes. We're not trying to disprove that you are not eligible. I'm using that air quote for that word because I'd like to replace that if we could. But thinking about like, how can we include you in what we have to offer? So how do we make victim services more trauma informed? And also reflecting and balancing the reality that we have guidelines of a program that need to be upheld. And sometimes somebody's experience doesn't fit within the guidelines for whatever reason. So then how do we talk about that in a trauma-informed way? We want people to leave our interactions with a sense that their experience matters, whether we're able to serve them, fulfill a claim, or whatever barrier may be there. We want to still, contribute that their experience matters. To set the stage for trauma-informed care and how we write and interventions, I love this quote from Judith Herman. She's really a pioneer in trauma work. She's got an incredible book called Trauma and Recovery that has long stood the test of time in this field. And she writes, no intervention that takes power away from the survivor can possibly foster his or her recovery, no matter how much it appears to be in his or her immediate best interest. I love that quote. As people that do this work, that chose this work, that ended up in this work because something in our life led us here, I believe we all come from a place of wanting to reduce people's suffering, right? People come into our spaces with this heavy burden. And through our work, through the things that we know, believe, study, and champion, we believe that there's a way to transform that trauma and life can improve. And a person that's been impacted needs to walk their own path. Again, we're going to use that example with a survivor or somebody who's been impacted or has lived through a domestic violence situation. We might believe it's in their best interest they make a change now. They might feel less safe, there might be other considerations that don't think that may not be in their best interest. So we want to be aware of that. Trauma-informed care is a strengths-based framework. Our person-centered language and what we write is going to come from that space. And it's going to be emphasizing the safety for both providers and survivors. So emotional safety is going to come from being aware of the way that we talk and correspond with people. Also being aware of their trauma, what they're bringing with them, their trust or mistrust and betrayals of the system. So you can see we're building a framework that shows you that who that person shows up with, all that they've experienced and carried, comes to the door, and that by us being aware of that, we're going to try to create a safe opportunity to rebuild some sense of empowerment. So trauma-informed organizations and programs deliver services that are based on the understanding of the vulnerabilities, what might activate a trauma survivor, and try to coordinate our services so that we don't exacerbate these wounds and we avoid re-traumatization. The key elements on being trauma-informed as an organization or individually are these 4 R's. Some people talk about extra R's, resilience being one of them, recovery being one, but these are the 4 that SAMHSA really promotes, and it's pretty simple, easy to remember. We want to realize the widespread and impact of trauma and that there's multiple paths for recovery. And in fact, the work that we all do, whether it's assisting somebody through an application, being a system advocate through a legal proceeding, we are doing something by our presence that can promote a path for recovery. Recognizing signs of symptoms in trauma, in the clients, in each other, in our staff, in all those involved with the system, and then responding with that fully integrated knowledge about trauma and infusing that into our policies, our procedures. This is where our writing and our correspondence comes into play. And by doing all that, we actively resist re-traumatization or further traumatization. And trauma-informed organizations and on all levels, victim advocates, system-based advocates, navigators, claims investigators, attorneys, each service providers, every single one of you has specialty-based knowledge on who you serve in the context that you serve them, and collaborate with your peers. Share the knowledge that you have of the work you do. Share it with me if I don't understand that about those that you're serving. That helps us all be more responsive and more trauma-informed in the work that we do. You collaborate, you use your subject matter expertise to help each other in this work. And these 6 principles are the underpinnings of all trauma-informed care. I love these because they're completely transferable to everything that you do. You've heard me talk today about creating safety, trustworthiness, and transparency. We're going to talk about a little bit more when we get into the actual written correspondence, peer support, how do we support each other in this work? Collaboration, which we just talked about, and empowerment, voice, and choice, which has come up multiple times today. I don't think you can talk about victim services without talking about empowerment, voice, and choice. People don't have a choice. Traumatic experiences are thrust onto them. Remember what happened to you, not what's wrong with you. So we want to be helping to restore that empowerment, voice, and choice. We cannot do any work with humans in any area of victim services without taking into consideration cultural, historical, and gender issues as well. And I'm going to go back to this really quickly. These principles, once you commit them to memory, you can't unsee them. You see them everywhere. You're like, oh, wow, I didn't really give that person a choice there. Or I'll hear myself like, oh, you need to do this. And I'm like, oh, I'm telling somebody what they need to do. So you start to hear it. It's not about perfection. It's about progress and being on the path to continually just doing better. So we take all these principles of trauma-informed care, our knowledge of trauma, and we start to think about trauma-informed victim services, because trauma affects how victims see themselves, the world, and their relationships, right? So these beliefs are going to affect how people that have been victimized respond to services and to the criminal justice system, to task forces. So when we look at this trauma-informed approach, not only through service delivery, but in every aspect of walking somebody through a process, whether it's an investigative process with the criminal justice system, the compensation process, or just the system in general, we want to be thinking about how not to, resist reactivation. We want to be trauma-informed. We want to be in that mindset that what they've endured affects everything about how they see the world. We will improve access. We will improve quality of care and access by how we interact with people. And this information, there's really great resources. The Human Trafficking Trauma-Informed Guide on how to work with survivors of human trafficking. So I think, even out of the scope of what your typical population that you may serve as, it's interesting to go look at other resources and see how other folks are talking about this as well. Because anything built on those 6 principles and those 4 R's, we can transform into our personal subject matter expertise. Wanted to give a shout out here for person-centered language. I know I worked at a hospital. The time I was working in that setting, this was a big push. This is how, we're identified, how we want to be identified. I don't want you to decide who I am and how I identify. So using person-centered language means respecting every individual's dignity, worth, choice, quality, strengths, and keeping the person at the center of the communication for the purposes of our webinar and conversation, not the victimization, not the illness, not the diagnosis. So it's the person first, and they have experienced. And I hear myself whenever this training comes up, because we use victim, survivor, I'm trying to move towards person impacted. And I also realize that historically, the field, we talk about victims and survivors. And I'm just thinking about how we can, organize that language in our minds, especially when we're client facing. And here's an example of a person-centered reframe. They're a crime victim. They're a victim of crime. They're a person impacted by crime, person impacted by violent crime. I work on the consulting side in communities impacted by mass violence. I like person impacted by mass violence. I think it offers a more inclusive opportunity for people to come forward. If we hear victim and survivor, where does your mind go? And if you have a response to that, put it in the chat. We'd love to hear. Sometimes my mind goes to a primary victim, to those injured, physically injured. And that doesn't always go to those psychologically injured, bystanders, first responders, family members of the person, of a person assaulted. So I think thinking about that language can be really helpful to expand the inclusivity and less stigma about being called a victim, being called a survivor. I talked about shame earlier, and I share here for the purpose of this conversation. I think it's useful. I know for me, after my personal experience, I didn't feel like I could call myself a victim because other people lost more. I didn't feel like I was a survivor because other people survived more, right? So I think thinking about that unique individual and what do they come to you with, and having that conversation. Here's some more examples of person-centered language, and you'll see here when to use victim or survivor. And I already mentioned, but victim sort of being the historic legal term used in the criminal justice system, which I think victim services ends up feeling like it's an extension of at times. And then survivor typically being thought of the more empowering term that aligns with a person's exhibited resilience. So, and they give a few tips here. So I love this little resource, like, how do you feel about these terms? And you can even say it to somebody if you're talking with somebody, you know, you'll see in the correspondence, we use victim. How do you feel about that term? I just want to let you know it's, you know, whatever conversation you can have. It's part of the way the letters are written, but I want you to know it's important to me how you prefer to be identified. You can see some other examples here of deficit-based language. I mentioned this earlier, addict versus person with substance use disorder. And now that's even evolved further to substance misuse. Things that I hear in my work, oh, they're so manipulative. You hear that in the clinical realm, and that is a reflection sometimes maybe of what frustrations we may experience as a clinician. Resistant, frequent flyer, you hear that a lot. Somebody that's in and out of services, what it's necessary for them. So thinking about ways to take these terms that become part of what we hear in our individual communities and thinking about how to make them person-centered and how to transition them to be more strengths-based, right? Away from what's wrong with you towards what happened to you. So ask yourself, when this is going on in your own mind, is this frustration? You're working really hard on somebody's behalf and they don't follow through. It's really frustrating, and it is coming from somewhere. I know I've had that experience in the clinical realm myself. Is there a question we want to address there?
Yeah, there's a question about asking which term they might prefer or if that might be inappropriate.
I think it depends on what your role is, I think. But if you're engaging with somebody and there's a lot of correspondence, so the compensation process specifically, right? We're talking about people who have been victims of crime. So I think it's okay to say, you're going to see that the correspondence says these things. I'm just curious how you feel about those terms. If there's one that you prefer, I don't think that we should ever just label somebody as one or the other. I think in the clinical setting, this may come up more. People will come to terms with how they categorize their personal experience. Okay. Now we're going to move into some trauma-informed correspondence. So, set the stage here. This is from the National Center for Domestic Violence, Mental Health, and Trauma. And the quote is, what and how you write is as important as what you say. Yes, yes, yes. This is a low-hanging fruit to make positive changes in interactions with those that you served. Trauma-informed considerations is a hot topic. It's very fluid. Language nomenclature is changing continually. 3 years ago, we used the word triggered. When somebody's activated, we're getting away from that word, because now with the last 5 years, the uptick in gun violence being the #1 killer, I think, of all children today nationally, is not a great term. So now we're using activated trauma cues. So you can see how the language is continually changing. Interest in traumatic stress and traumatic stress studies was sort of in the late 90s coming to the top of the field, and post 9/11 really came into the limelight. So historically, you can even see it's a newer study and conversation. So historically, letters and communications were very legally oriented, and there has been a movement nationally to revise. And your state, New York State, is taking initiative here to make these changes and start to explore how to implement practical changes. And I'm going to, give a little shout out here to New York State for being willing to say, I think we can make changes and let's do it. So this is a really important topic and time to be doing this. So in the chat, if you have a phrase, a term, something that makes you feel cringy that you hear in correspondence or in just those manipulative, frequent flyer, addict. If you hear a term often that you don't like and you'd like to see change, put it in the chat. Because I think this is a really good opportunity to start. If you share that, somebody else can go, oh, I say that too. We can't help it. Again, the field's always changing and developing. So if there's something that you've come across that you really feel is particularly not victim-centered, let's put it out there. All right. Anything in there we want to share? Okay. So what is the goal of communication? I'm primarily talking about written communication, but I think one of the useful strategies about looking at written communication is you can think about how do we use that in our verbal communication as well. So especially specifically if we're thinking about the comp process, which is only one aspect of victim services, what is the goal of communication? So for the purpose of just giving an example, it would be to make a determination on the eligibility of the claim for benefits. So how do we communicate that the experience and victimization matter if we have to issue a denial letter? How do we communicate that somebody's experience still matters if they're not within the guidelines of the program? Maybe there was contributory conduct. And keeping in mind that as an institution, we already mentioned this, you're a position of power, and there may be historical mistrust, there may be betrayal. So we're thinking about all these things, right? So we want to collaborate. We want to try to support healing through transparency. I think people really appreciate transparency, and that's having direct, difficult conversations sometimes about why somebody's application may not be within the guidelines of the program. And I think when we are thoughtful and intentional about how we communicate through correspondence, we're also letting them know that information can be unsettling, it can be distressing, and we just want people to know that we're not seeing them as a unique individual. So if, specifically, I think if we have to issue a denial letter in a compensation process, we want to be thinking about how to do that sensitively. And the transparency, say we are talking about a compensation or process. I don't know how long it takes in New York State right now, but in multiple states, it takes up to 9 months to have a claim go through a review process. And that transparency, okay, we've gotten through this process, all the necessary paperwork's in, everything's signed, and it could take 9 months. I don't want you to think that we're forgetting about you. So that transparency about how long the process could take. When we think about writing and communication tips, whether it's coming from a comp office, a victim advocate, a legal, clinical, we want to be thinking about being short, clear, and concise. The national reading level currently is around 6th grade. So be thinking about how overwhelming it looks. If you open a letter and it's full of words and reading is not your strong suit, what do you think people do with that correspondence? We talked about this activation. It feels overwhelming and we put it down. Can't even look at it. There's just too much there. I don't know. I mean, that is a natural reaction for many people. It just feels overwhelming. We want to consider what it looks like structurally. I was just talking a little bit about that. If there's too much, it's just too much. If we can't help but have a lot of information on a page, but there's a little section that we can indent and maybe bold, because this is really important. then maybe we can skim all the other stuff and look at that bolded, indented section. Bolding dates, maybe even bolding signatures is super helpful. I know specifically, again, with the comp process, if things aren't signed and dates matter a lot, return it by this date, or then we end up, in some kind of processing issue. So bolding, just structurally looking at it, whenever possible, using plain language, and avoiding some of the legal and technical terms when possible. That's our best case scenario. We know that you can't always do that, right? There are things like contributory conduct, and there's information about a hearing process and all those things. We can't. So sometimes it's helpful to make a phone call. Hey, I just sent you the letter about the upcoming appeal hearing. I wanted to check in. It's full of legal and technical terms. Is there anything I can help decipher? Right? So just thinking about how can we make the process more accessible and more readable? And considering those structural elements, which we already mentioned. Additionally, this is one of my favorite things to talk about, and I feel like this infographic helps communicate what I want to say here. And this is from the National Center for Domestic Violence, Trauma, and Mental Health as well. They have a great guide online. It's the issue of command language, how information is communicated. Sometimes simple word adjustments change the whole meaning of something. So for example, think about an appeals process and thinking, avoid, replace, avoid. We want to avoid accusatory and blaming words, focus on empathy and validation. I have seen so many comp letters that say, failure to sign and return this form by this day means that you are ineligible for an appeal forever, right? And I get where command language is coming from. It's what we're saying, your victim services folks, what we're trying to say is, it's so important that this letter is returned by this date, or we can't schedule the appeal and we want you to have it. That's what we're thinking, right? We're like, this is so important. So we bold the date, failure to do it. But think about what it would mean to somebody with no voice, no choice, if we said, you have the right to an appeal this decision. Sign and return it by bold this date. We can use that command language from this empowerment, voice and choice place. You have the right to an appeal. Check this box by this date, send it back, and then we can schedule it. So we're trying to communicate the intensity of the importance of it. We're just thinking about how to transform the language a little bit to make it empowering. So that trauma-informed principle, how do we use that to empower this situation? So another example would be, and this might be in conversation, like, oh, did you make a police report, or why didn't you make a police report? That's just an example. And not that we would ever say that, like, oh, did you make a police report? Understandably, you may have been super overwhelmed at the time and may not have thought, or may have had a reaction that prevented you from, so just thinking about how we can replace difficult questions. These kinds of skills are better practiced ahead of time. It's really hard in an intense moment to come up with new language. I encourage people to have a little living document. You can do it within your own group or team where you have little smart phrases. Oh, I was on this really tough phone call and I said this and the person really responded well. Great, put it on a thing, share it with each other. Come up with that little smart phrases that you can go to during intense moments. And all this we're doing to avoid re-traumatization, being mindful not to force victims to relive trauma, like, why didn't you go do this? Or who did you tell? And that empowerment, voice, and choice, back to that. And, it's such a small change, and it, I think, has a big impact. If others think it would have a big impact to say you have the right to an appeal versus failure to sign and return by this date, let's give a thumbs up in the chat for that. So the other thing about trauma-informed correspondence, and you can apply this to anything in victim services, if you have to email, correspond, whether it's a comp process or any other process, we want to be thinking about opening all correspondence with a tone that acknowledges sensitivity to the content or to the reason for communicating whatever the correspondence is. And I just gave a little example of an intro here, and something like being a person or being impacted by crime can cause overwhelming feelings or reactions. Please take your time and read the documents below carefully and thoroughly, as they contain important information regarding the claim for compensation. So say this was an intro for a compensation. We've received your packet. By starting with being impacted by crime or being a person impacted by crime, whatever sounds right to you, we're acknowledging that they're not necessarily a victim or a survivor. We see that you've been impacted and we're being trauma informed. This can cause overwhelming feelings or reactions. If we go back to our info on trauma, right? We can get anxious, we can be forgetful. So we're telling you, we get it. This is an empathetic opening. We know that this could be hard. And because it's hard, it could be activating. Read carefully, read thoroughly, because the information contains important information. I highlighted the claim for compensation in yellow. This has been a little pet peeve. I feel like has a lot of bang for the buck. The claim for the compensation versus your claim. I believe when you tell somebody your claim has been denied, you're telling me my experience has been denied. If the claim has been denied, my experience still has a chance to matter. So it's the claim for compensation. I'm me, I'm submitting the claim. If it's the claim and not your claim, I feel like that works a lot. It goes a long way of creating that sort of person-centered, trauma-informed way of acknowledging something happened, your experience matters, and it's not within the guidelines of the program, so it won't be fulfilled at this time. That's just, I'm probably in the weeds a little bit on that, and we can talk about that more in different training sessions. And then also thinking about how to close all your correspondence. Again, this is specific to compensation, but you could take language and amend it to, although it may be difficult to understand the limitations of the program, of the compensation program, of the legal system, please be advised that the outcome of the hearing, the application, whatever it is, doesn't diminish the significance of your experience as a person impacted by crime. And, or, thinking of ways that reflect the culture of your work, of your organization, on coming up with a closing that's acknowledging something difficult we just went through and it didn't go the way that maybe we all would have liked. And, right, it's an and, it's not an either or, and what you went through still matters. And if you put your mind into looking at, a hearing, an assault hearing, for example, it's not, somebody doesn't always win that hearing, and their experience matters. And there's something to be gained by going through the process and having your voice heard. So even thinking about how do we come up with ways to talk to people about things not going as planned in the system and still managing to validate their experience. I also suggest that you sign any correspondence with a specific name and contact information, and whenever possible, offering trusted resources. And if you have a website for your organization or for the state office, what are the trusted state level or national level resources? So for example, say it was mass violence, there's a National Mass Violence and Victimization Resource Center that's funded by a cooperative grant with Department of Justice. So that would be a trusted resource we could put. There's a National Center for Domestic Violence. There's Survivors of Homicide. So there's some national organizations that we could put where people can go to find peer support. They can go to find trusted resources. So those are just two examples about email correspondence, written correspondence, official letters that go out, just thinking about what kind of opening and what kind of closing is compassionate, is acknowledging, and shows from the outset that you are a trauma-informed thinker and or organization. So just some suggested edits or revisions to make and explore. An ideal denial letter if somebody's not within the guidelines of a compensation program, or if funding runs out and somebody can no longer receive services, or if they've completed a course of treatment and they can't stay in a program, whatever the denial needs to be, thinking about language and how we can talk about that with somebody. If we can't change language, if we can't edit things, thinking about a personal warm-up letter or email. Okay, we are a trauma-informed organization. We strive to, deliver services in a compassionate way, and we are bound by certain legal and technical requirements of the system. I just want you to know that, and if you have any questions or concerns, here's specific contact information to reach us. This training we've done in the past, and your friends from Massachusetts created an amazing glossary of terms that shows up in their very legal and technical correspondence, and that's a great resource to have on a website to mail out to people. Your neighbors in New Jersey created a checkbox appeal sheet. We got away from the page of all the stuff and dates and warnings and command, and check the box yes, check the box no. Completely simple. So there are creative ways to come up with how to increase accessibility to services. So what does that look like? Instruction sheets, whether it's for an application, whether somebody has to apply for state insurance before they can access funding, all of these processes can be super overwhelming. So a short, clear, concise, clean instruction sheet. This is what you need to do. Step 1, step 2, step 3. Specifically, if we're looking at compensation, language around contributory conduct, things like that are really difficult. It's very painful, both for whoever's coming forward to apply for compensation and, for the trauma that they've already endured. And also, how do we ask for police reports and medical records? Again, we were talking about collaborating with other people with subject matter expertise. Your system-based advocates, they're your go-to people. They're going to tell you how to talk to people about anything that has to do with the court process. They're going to have great tips and information. And then think about things like the appeal form, which I already mentioned. How can we make, always thinking about increasing accessibility. I know when I heard Director Rose from Office for Victims of Crime at the VOCA conference talking about goals going ahead, it's all about increasing accessibility. I think developing a checklist for your organization is a great idea. I think if we can, and each internal organization get together, do this as a group or a community, get your leadership team together, get your clinicians together, whoever wants to take this on. Again, a low-hanging fruit to make a positive change. A mini inventory that works for you and your organization. Is there a language barrier? Are we doing everything we can to increase accessibility? Is there digital access or a divide? We're doing so much on computers now. Sometimes they don't transfer well to a phone. Desktop and phone don't always, if you need a signature on something, but somebody can only access it on their phone. So how do we increase accessibility? Thinking about that checklist. Okay, this person doesn't have access to a desktop. Where's the local library where they can use a computer? So thinking about problem solving to increase cultural considerations. that trust, mistrust, betrayal. Am I being as person-centered? Am I taking this whole person into consideration with this correspondence? Always, always, always having that in the front of your mind and coming from a place of cultural humility. I can never stop learning about how to appropriately and best serve anybody who doesn't look exactly like me. Promoting safety in everything that we do that with language, we do that with those trauma-informed principles, we do that with taking care of ourselves and with our colleagues. Is the language in the communication non-judgmental? And if you have to make a difficult phone call, thinking about language, we are people too. So when we feel defensive about somebody I should say me, when I feel defensive if somebody's questioning my work process or what I'm doing, then I have to look back at me. Am I being defensive? So my language I might feel judged. So is my language showing that? Making sure the content is not too overwhelming, either by how it looks or by how much there is on there, or because of command language. Are we being transparent and creating safety? And does the correspondence promote that transparency by, hey, there's a timeline here, it's going to take a long time, I'm going to have to ask for really delicate information, I'm going to be needing, hospital records. And on a good day, that's overwhelming in and of itself, right? We're talking about activation. I have to go to the hospital and ask for records. I have to make an online inquiry. I'm on hold. I get passed to 10 different departments. Oh, you need a signature for me to request my records. It can get very overwhelming. Do we offer resources on websites or on the bottom of closing correspondence? And then signing from a specific contact person. And I will say on a checklist, always asking yourself, would a phone call be helpful? Sometimes a phone call goes a really long way and can, offer solutions to questions that people have trouble asking. I could go on and on about the barriers. There's interesting research that people with language barriers feel shame and don't ask questions. So even thinking about that, like how do we always increasing accessibility? So to summarize, elements for trauma-informed written correspondence: readability, clear and concise writing whenever possible, plain language to increase accessibility, thinking about how it looks like on a page. Is it overwhelming? Could we break things down? Guiding the reader through the process, using inclusive language whenever possible, being person-centered, keeping the person at the center of the communication, not a victimization or illness. That command language, which often comes from the most well-intended place. And then those trauma-informed principles, can we see, throughout all the correspondence, whether it's an email, whether it's a formal document, can we see that we're thinking about trust, transparency, we're taking individual, person-centered, we're coming from a trauma-informed place. The benefits of trauma-informed practices, specifically if we look at a comp program, and we've been starting to do this training in enough states now to have anecdotal feedback where people are telling us, we are getting less phone calls. We are getting less phone calls where people are really angry with us. We have one of the top reasons applications are not fulfilled for compensation is that they're incomplete. I think it's because they can be really overwhelming. So thinking about that, how do we increase accessibility and fewer incomplete applications? I think in New York State, I looked at the last year's final report. I think incomplete applications was the top reason a claim was not fulfilled. And then by being trauma-informed, by increasing accessibility, not only are we reducing the secondary stress experienced by staff, but we're also helping to make sure the funds go to help and support the recovery from being a victim or a person impacted by crime. That is what the purpose is to ease the emotional, physical, spiritual, and financial burden of enduring something that's thrust onto you. So that place of yes, and how can we help work through this process? I wanted to leave time for some questions. And do we have any questions or comments?
There were a couple comments in the chat related to reading level and accessibility. I know there's been times even here at OVS when we change something from victim to individual impacted by victimization or crime, it immediately raises that reading level. Can you talk a little bit more about balancing reading level and trauma-informed and accessible language?
Yeah, I used a software called, I think it's called Readability. And you can put documents or emails or anything through it, and it'll tell you what the grade level is. I do think there are more common terms and phrases. I mean, you could even put victim and then in parentheses, person impacted by crime, or you could put person impacted by crime and put in parentheses, victim of crime. Because I think that demonstrates, okay, we understand this may be more typical and readable, and in the nature of wanting to be more trauma informed, we want you to know that we're thinking of you as a person who's been impacted by this, versus just a victim of crime. So I think that there's ways you can do both. You can maintain that that change without it having to increase the reading level, or the you know, the level of being able to understand what the communication says. And you can even, one organization that we did some work with, we came up with a letter that said, you know, we're striving to become a trauma-informed organization, and we're changing some of the language, and here's what it means. So there's all different, you know, workarounds that you can do within the culture of your specific organization that feel right for you. I think statewide letters, even if you want to transition, and you could also put it on the glossary of terms. You know, we are replacing victim as with person impacted by crime.
There is a comment asking about when the next training is. There's a lot of great information going around. So if you like this training, please complete the evaluation that's going to be sent out right after the webinar ends, and then also an email that will be coming in a few days, and let us know that you want more, if that is in fact the case. There was also some questions related to individuals that might not have English as their first language, and there being a disconnect using a translator, and recommendations for how to try your best to keep that interaction as trauma-informed as possible, while also recognizing that things might not always translate.
Yep. Yeah, this is a real issue, and helping to increase the amount of providers that are proficient in other languages, especially specifically in a certain area. I did some work with a community in Florida that had a large Haitian population. And, you know, that language is very specific. We just did some work. Yeah, so this is a very important consideration. So anytime we can, and there is a national shortage of providers that speak multiple languages. Collaboration, if you do have somebody, say one of your victim advocates, you know, is able to help proof something that you're sending out, or bringing a victim advocate into a conversation. This is definitely an ongoing national issue, full stop. I'm not sure what else to say about it except for that. At the hospital I worked at, we used a translation service called Voice, which you actually get a live person on the line who is an official translator, and they translate in real time. So you're sitting with somebody. I use Voice. I ask for somebody that speaks, Spanish, for example, and then they translate in real time. And I think too, cultural considerations come into play here too. You may have certain cultural backgrounds that are more of a collective culture. They may bring multiple family members into a situation. Sometimes a family member is able to translate in that way. I know that's not always ideal for confidentiality and privacy. So this is a complex issue. Yeah, complex. So I think the most common languages in your area, the documents probably are already transcribed. And then I think having services, even deaf and hard of hearing services and other accessibility services, how do we set up our infrastructure to have those resources is essential to victim services.
Thank you. There's also a couple resources that folks are sharing in the chat related to language access and
Awesome.
cultural connection.
I would love those resources as well. That's why we use the chat, so we can help each other, because I know I have resources that I use, but I always love learning what other trusted resources others have. So thank you for sharing them and keep them coming.
There was a lot of mention of compensation language here, and there were a few questions specifically related to New York State compensation. So we're not able to answer those in this space here, but if you do have questions, you can always follow up with Blake or myself or even the training inbox that you'll get an email from in the coming days, and we'll connect you to the right person to get those questions answered.
Yeah, I think legal and technical language, whether it's with the system-based advocates or even anybody working in victim services, it's super helpful to come up with in your organization. I love the idea of a team meeting. We create a living document and a checklist within our own individual organization. For continuity, here's the language we agree as a group works for us. That's trauma informed, and it helps describe those kinds of communications the best possible. It's a nice team building activity as well, because you get that back, and especially in a multicultural setting. No, that term, we don't like that. I don't like that. This is why. That doesn't feel good for me. This is why. Hey, you're not thinking. And even, further cultural competency activities are essential.
All right, not seeing any more questions. Blake, is there anything that I missed in the chat or the question function?
No, Lauren teased it a minute ago too. The want and need for more training like this is wonderful. So do your evaluations. That's helpful for us to determine that. But also I do want to share, and Amy alluded to it earlier, that we are also working separately and directly with Amy on updating some OVS language that's used from everything from compensation letters to letters from our legal team or announcements that training and outreach uses too. So more to come. We're always evolving, and this feedback is greatly appreciated. Maybe give it one more minute for any last questions.
Yeah, I mean, if anybody's thinking about last questions coming in, I would like to thank you for choosing this work. It's hard. It's different than what a lot of our friends and family members do, and people don't always understand it. And there's something very special about anybody who's willing and able to put themselves alongside somebody going through often the worst times in their life. And it's a special skill and a special human to create that trusting environment and to be willing to always keep learning and developing so that we can serve people and our neighbors, our friends, our community members, so that they can, have the kind of life that we all wish for. And in that, always thinking about taking care of yourself. I know we don't do it. I was talking to a colleague and he, what are you up to? And I was literally sitting in bed working on a presentation with like 2 awful books on horrible traumatic situations. And he was like, what are you doing? Set down boundaries. I'm like, you know what, you're right. Right. So it just creeps in. I think people that work in victim services, victim advocates are some of the most special, compassionate people that there are. So we need you, the world needs you, and we count on you. So take care of yourself along the way and build that into your practice. And that's part of being trauma informed is how you can take care of yourself.
Very well said. Well, thank you, Amy. We appreciate your time today. Thank you, everyone, for attending. Give us a day or so to get this uploaded to our YouTube channel, and then same time frame or so for a follow-up email that will come with all of the links and resources that we talked about today. So
Yeah. And
thank you,
thank you
everyone.
for
Yeah.
giving me your time this morning.
All right, everyone. Have a great day. Take care.
Thank you.